Welcome to this webinar, everyone, on how to commission evidence-based programs. Hopefully everyone can hear me clearly and can see the slideshow in front of them. My name is Trude Nederwald, and I'm joined by my colleague Nick Axford today, and we are both from the Social Research Unit, and we will be delivering the third webinar of the Youth Justice Board's Effective Practice series. We are a charity located in Dartington, dedicated to improving outcomes for children, and we've been commissioned by the Youth Justice Board as independent experts to deliver this series of webinars. This webinar is the third of the series of 5 webinars, and it's on how to commission evidence-based programs. You can find the recordings of the first 2 webinars on our website, and the topics of the upcoming webinars are shown on the slide in front of you. All webinars support the launch of the forthcoming innovation and evaluation in youth justice materials, which are designed to provide youth justice practitioners with advice and information about program development and evaluation. We are really grateful for everyone's feedback to our first 2 webinars, and we truly hope that you continue to provide it. We will be sending you a link to an online feedback form after the webinar, and we would really appreciate it if you could spare a few minutes to complete the feedback form. The webinar itself should last about an hour. It is divided into 2 parts. We start off by giving you a presentation that will be followed by a discussion where we will take the questions that you are sending through to us, and Nick and I will try to answer those questions. In case we don't get through all of the questions in the discussion session, we will collate the frequently asked questions at the end of the webinar and share these later on like we've done on previous occasions. So I'm going to hand it over to Nick now so he can kick off today's topic.
Okay, today's webinar focuses on how to commission evidence-based programs. As you know, there are a number of evidence-based programs out there that commissioners can consider when thinking about commissioning interventions. However, the commissioning process requires more thinking than first meets the eye to ensure that we maximise the benefits we could get from these programs. Different aspects of commissioning and innovative ways of financing as part of it have become particularly important in the context of limited resources. Take the Troubled Families initiative, which seeks to turn around the lives of the country's 120,000 most troubled families by 2015. As part of the national implementation plan for this, the Department for Communities and Local Government is making £448 million available over the next 3 years to support interventions designed and led at the local level. Local authorities are being offered up to 40% of the cost of these interventions to be paid once successful outcomes, including reduced crime and antisocial behaviour, are achieved for local families. This results-based funding scheme is just one of many initiatives designed to support effective commissioning and currently being piloted. So, what is commissioning? The easiest way to think of commissioning is as a decision-making process. The role of a commissioner is to understand what the problem is and then work out and put in place the best way to address it within available resources. The commissioning process, however, is not only about the commissioner. Charities and social enterprises seeking to get their services procured by the public sector also need to understand the commissioning process. Overall, the commissioning process can be captured in 5 steps that you see in this slide. These steps aren't always clearly distinguished from one another and can be carried out over different time periods. We're now going to go through each step in turn while focusing more on those that are particularly relevant to the commissioning of evidence-based programs and which we won't consider in future webinars. The starting point of any commissioning process is to establish what the problem is you're trying to address and what is causing this issue to arise. Without this information, you won't be able to select the best course of action. The list of evidence-based programs is useless without information on needs that have to be met. You can be guided by government policy which explains key issues or populations to address. However, what you really need is data on the needs of local children and young people. You want to know how many children have certain needs and who they are. So what sort of data are we talking about? What we need is epidemiological data. Epidemiology helps us to understand the nature and extent of problems like youth offending and associated risk and protective factors in the population. You may know the story of the Victorian doctor John Snow. Working in 1854 in what is modern Soho in London, he plotted deaths from cholera on a map. Each small rectangle on this map is a coffin representing a death from cholera. He noticed that these clustered around a public water pump in Broad Street and concluded from this that dirty water was the cause of cholera before allegedly ripping the handle off the water pump. Previously, it had been thought that cholera was caused by bad air. Snow showed that this was wrong by investigating the distribution of the problem and its potential cause. The epidemiological data can help to focus attention on the most important local needs and inform the strategic commissioning of evidence-based programs. Without such data, local authorities and other agencies do not know which aspects of child development may be an issue compared with the country as a whole, and they do not know how to target the right evidence-based programs on the right children and young people. Gathering such data on needs used to be prohibitively expensive, but there are now several needs data tools that can be rapidly applied by local authorities or communities without great expense. For example, at the Social Research Unit, we've developed an epidemiological tool called Children Count to measure children's needs. This has been applied to over 100,000 children and young people in local authorities and communities in the UK, Ireland, and the US. Through a household-based survey of parents of children aged 0 to 8 and a school-based survey of children aged 9 to 18, the tool measures a range of health and development outcomes covering children's behaviour, emotional well-being, educational skills and attainment, relationships and physical health. It assesses a range of risk and protective factors at the individual, family, school and community levels. Good data on needs can help commissioners to prioritise risk and protective factors and outcomes for intervention. To illustrate, this graph indicates outcomes where children in a given city are developing on a par with, better or worse than children nationally. The bars reaching upward indicate that they are doing better, while those falling below the central line show where children are doing worse. In this example, children's physical and emotional health are relatively good, but their social functioning is a cause for concern, suggesting that it might be an area to prioritise for improvement. The information can also be used to help estimate the size of a realistic improvement in child outcomes. For example, this graph shows that the behaviour of the average child in the city, represented by the blue line, is significantly worse than that of the average child nationally, and that nearly twice as many children have a likely conduct disorder, 21% compared with 11%. Armed with such data, you can begin to think about how much change is possible and what this would take. For example, halving the rate of conduct problems might be over-optimistic, certainly over a short period, but perhaps with a portfolio of evidence-based programs and over a couple of years, it could be reduced to much nearer the national figure. Once we have analysed these data on children's needs, we can start selecting evidence-based programs to bring about the desired change. So, what would you need to consider when selecting evidence-based programs? Most importantly, you would need to consider evidence on what works, which programs work the best in achieving the outcomes of interest, for example, reducing offending or improving social skills. In our last webinar, we talked about clearinghouses of evidence-based programs. They work a bit like the Which magazine, except that instead of listing fitness gadgets and washing machines, they list programs. Information is provided on each one, covering things like target population, details of how the program works, what outcomes it aims to achieve, what is required to implement it, how it's been evaluated and with what results, and whether it generates a desirable benefit to cost ratio. We also said that clearinghouses have different standards of evidence to determine what works. Arguably the highest standard is set by Blueprints for Healthy Youth Development. Such clearinghouses form a valuable resource to inform the selection of evidence-based programs. These sources will spark ideas, especially when placed alongside other data sources about local need, for example. Sometimes it will be possible to select a portfolio of programs from the various databases. At other times, it will be plain that there is no off-the-shelf solution to a local need, in which case the data will provide a context for a fresh innovation. In addition to evidence on what works, you need to consider resources available to you and the investment required to commission evidence-based programs. The cost of programs is a critical aspect to take into account. However, rather like an investor on the BBC TV programme Dragon's Den, a smart commissioner also considers the short-term and long-term benefits of these programs. Many evidence-based programs not only improve outcomes for those who take part in them, like reducing reoffending, they also help to save money. Some other types of program may have an impact on desired outcomes, but they save us little money in the long run. Some effective programs carry a higher risk of losing money than others. Data on costs and benefits can help the commissioners to come up with a selection of programs that is right for local conditions. One of the most rigorous methodologies for cost-benefit analysis has been developed by the Washington State Institute for Public Policy. It's cautious in its estimates of savings. It has applied the same modelling approach across a range of policy areas, which means that policymakers can compare the results of different programs in different areas. And it has been used to inform real policy decisions made by Washington State. We're in the process of applying this model to the UK in a project called Investing in Children, and one of the areas that we've looked at is youth justice. Here you can see a summary of cost-benefit data on functional family therapy, or FFT. What this summary tells us is that for each young person, it costs just over £2,500 to implement functional family therapy. It also tells us what the benefits are of the programme, and it breaks those down in terms of the benefits to the taxpayer, participants and victims, and you can see that that comes to just over £31,000. On this slide you can see what the net benefit is of functional family therapy, and you can see that it's about £29,000. This also shows us the risk of loss. Because it's 1%, what that tells us is that 99 times out of 100, when you implement functional family therapy, you will at least break even. Together, these three types of data on needs, data on effectiveness, and data on costs and benefits, can empower local commissioners to design evidence-based prevention strategies. I'm now going to hand back to Trin, who will cover the next steps in the commissioning process.
Thank you. Now, the second step in the commissioning cycle involves developing the market. Market development is a process involving a partnership between community members, service providers, and local authority commissioners. In order to shape the market in a direction that supports the strategic commissioning of evidence-based programs, it is essential for commissioners to understand the supply of services. This is often called market intelligence, and it involves understanding the structure of the local markets. It requires gathering information on several things: the number and types of suppliers, the range of current services available and at what price, and the drivers of the market, which could include leaders who value evidence and organizational learning culture and focus on outcomes. Market intelligence also means identifying its capacity for growth and innovation and barriers to market entry. For example, when public service markets are opened up to private and voluntary suppliers, they can have difficulties accessing those markets, particularly where the public sector is the major or only supplier. So there can be a perceived lack of a level playing field and a perception of bias towards public sector supply. This information allows the commissioner to identify which aspects of the market need to be developed and how. For example, it helps the commissioner to think about opportunities to build service provider capacity and incentives for the market. For example, innovation funds or investment to save money longer term, or perhaps promotion prospects for individuals. A related part of the market development is building demand. You need to make it attractive for people to deliver the intervention. To help with this, it is worth doing some market research about the program you are planning to commission. This doesn't need to be complicated. Find out what managers and practitioners know about it, what they think the pros and cons will be, whether they have any solutions to the potential cons, what the structure or context will be into which the program needs to fit, and whether there are competing options. This will generate useful insights about how to package and sell it, and if necessary, make adjustments to the program and to the system to achieve a better fit. So commissioners need to engage and develop potential providers that will be able to implement the evidence-based program. But they also need to work closely with volunteer and community organizations that may not deliver public services, but which are experts in the issue. It is also essential to include user-led organizations when possible. All this helps to build provider and consumer buy-in and foster collaborative relationships between commissioners, providers, and consumers of evidence-based programs. We now move on to the third step of the commissioning process, which is procurement. Procurement is the process of identifying and securing a solution by buying services to address the needs you have identified from the market you have developed. Procurement and commissioning processes in England, Wales, and Northern Ireland are governed by the Procurement Contracts Regulation, so we won't spend time on the legal aspects of these processes. Instead, we'll look at innovative ways to purchase and deliver evidence-based programs. Now, before we move on, it is important to acknowledge that commissioning does not happen only externally through a contract or grant funding relationship. In fact, many public bodies commission internally. The aspects of the external commissioning process that we discussed today can also apply to internally commissioned services. The first financing idea is the simplest and most obvious: reinvestment. Central and local government can free up resources from other areas of spending, sometimes even within the same budget lines, where that resource is spent on something known or thought to be ineffective or not a priority. Despite its simplicity, this solution is often difficult to achieve. The politics of stopping doing things are extremely tricky. First, nobody wants to cut a service that provides jobs, often in the volunteer and community sector, or that is simply popular. Many people still recall bitterly how free school milk for 7 to 11-year-olds was abolished in the 1970s, earning the then Education Secretary the moniker Margaret Thatcher Milk Snatcher. Somewhat unfairly, it later emerged since she was against doing this, but overruled by the Treasury. Second, there is an issue of political perceptions. For example, it may be difficult for government to redirect money away from building a prison and towards prevention and early intervention, as the Washington state legislature has done in the US, without being accused of being soft on crime. Third, siloed budgets at the local level mean that although it may be in taxpayers' interest to invest in catch-up reading tuition for 6-year-olds rather than on remedial reading programs for teenagers, the investment requires one budget holder to make the investment in this case the primary school, without seeing the financial benefits which accrue elsewhere. So systems are complex. Last, reinvesting from what doesn't work to what does work requires not just good knowledge about the evidence base, but also a deep understanding of how the money flows at the local level, exactly who is being served by what service, and whether those services are meeting the needs. A practical example of a reinvestment initiative is one of our projects called Redirect and Reinvest, which is about redesigning systems for looked after children. In this project, we have partnered with 3 local authorities to develop and implement a strategy for reducing the size of the care population and redirecting money into interventions that support a greater number of vulnerable children in the community. The strategy involves implementing clear and consistent thresholds for entry into care and identifying children who can return home safely. It also incorporates the use of evidence-based programs like functional family therapy as an alternative to being looked after. In a nutshell, these strategic changes should decrease the number of children going into care, shorten the time children spend in care, and where safe and appropriate, redirect children who would ordinarily enter care to the new alternatives. The aspiration here is that over time, authorities can invest freed up resources in targeted early intervention services. A second financing approach is payment by results. This relies on the commissioner, for example, central or local government, paying service providers for improved outcomes rather than for service inputs. Now, in theory, payment by results is a simple idea. People and organizations get paid for what they deliver. For example, any payment by results contract concerned with reducing reoffending should ensure that organizations receive the biggest payments when they succeed in getting prolific offenders to give up crime. This saves the commissioner, for example, the Ministry of Justice, and the country money and benefits everyone in society. These outcome-linked payments usually form part of the payment contract with the provider, the rest being made up by traditional payment for service. In these contracts, it is the service provider that takes on the risk of the outcome not being achieved. Project Redirection in Florida is an example of a large-scale payment by results contract. It was developed in a context of worsening teenage violence rates, overcrowding in residential facilities, and a public cash shortage in the state. So in 2004, the state's Department of Juvenile Justice contracted with an organization called Evidence-Based Associates, or EBA, to redirect troubled youth from residential placements to more effective, family-focused, evidence-based treatment options. 3 evidence-based programs were implemented: functional family therapy, pre-strategic family therapy, and multisystemic therapy. In redirection, EBA acts as a middleman, negotiating with potential service providers and investing in training and certifying staff according to national standards. Delivery teams are monitored closely for how well they implement services and whether they are achieving targets. For example, 75% of young people not offending during services, or 60% not reoffending 1 year after discharge, and so on. Apart from notional management cost, EBA only gets paid if outcomes are achieved. Project Redirection has expanded significantly since it started in 2004, when it served 154 young people. By December 2012, over 8,800 young people and their families had received one of the 3 programs. In an evaluation conducted in 2011, rates of felony reconviction for youth completing redirection services were 38% lower than the matched sample of residential youth. Rates of subsequent juvenile commitment, adult probation, and adult prison were 33% lower for redirection youth. On top of that, in the first 6 years, redirection has avoided millions of dollars in residential placement costs. In all, payment by results is a way of linking a proportion of payment to particular outcomes. The proportion of the contract paid on a successful outcome varies across contracts. In Project Redirection, the risk for EBA was actually quite small. Even though their contract included a set of performance measures in terms of reoffending rates, there was actually no financial penalty if they missed the targets. However, risk for the supplier can be much larger. Any supplier entering into a payment by results contract must therefore assess whether they can actually take on the financial risk of not achieving the results, especially in youth justice where organizations are still finding their way. A third innovative way of funding services is a social impact bond. This is like payment by results, but for service providers that are unwilling or unable to take on that level of risk, for example, small charities. Private investment is used to pay for interventions which are delivered by service providers. The public sector pays financial returns to investors on the basis of improved outcomes. If outcomes don't improve, then investors don't recover their investment. The public sector pays if and only if the intervention is successful. The Peterborough Social Impact Bond, launched in 2010, is the first example in the UK of a social impact bond. It was developed by the Social Finance in collaboration with the Ministry of Justice and the Big Lottery Fund. Social Finance raised £5 million from 17 social investors to fund work with 3,000 male short sentence prisoners leaving Peterborough Prison. Statistics show that 60% of short sentence prisoners reoffend within 1 year of release. This is arguably because they receive little statutory support to address the causes of their offending. The project is designed to reduce such reoffending rates on a payment by result basis. Social sector organizations, such as the St. Charles Trust and Ormiston Children and Families Trust, provide intensive support to prisoners and their families, both inside prison and after release. This support, which is designed to help them resettle into the community, includes help to find jobs, housing, and treatment for drug addiction. The Ministry of Justice and the Big Lottery Fund will pay investors so long as reoffending among the prison leavers falls by 7.5% or more compared with a control group of short sentence prisoners in the UK. If the social impact bond delivers a drop in reoffending beyond 7.5%, investors will receive an increasing return, which is capped at the maximum of 13% per year over 8 years. If this project proves successful, the Ministry of Justice has suggested that the scheme could be implemented more widely. We now move on to the fourth step in the commissioning cycle. And that has to do with the delivery of service. Once the contract has been signed, the service then must be delivered, managed, and paid for by the chosen provider organization. How to implement evidence-based programs is the topic of our next webinar, where we discuss things like recruitment of practitioners, participant engagement, implementation fidelity, organizational support, and so on. For now, we will move on to the final step in the commissioning process, which is the review of quality and impact on needs. Once the service or program has been delivered, it is time to review things. Evaluation of how the service has impacted on the needs identified at the outset is therefore essential to beginning the process of needs analysis again. So in this way, commissioning is a cyclical process, always requiring action to check and change services, resources, and the market to meet the new and changing needs. We end with a few thoughts on the challenges and advantages of commissioning evidence-based programs, and I'm going to hand it over to Nick.
Okay, thanks, Trin. So starting with the first challenge, the process of commissioning can be time-consuming. It takes time to develop a tender and receive and review responses to tenders. Added complexity comes from the fact that procurement is governed by legislation, policy and principles at both the UK and the European Union levels, not to mention internal regulations within statutory commissioning bodies. Secondly, commissioning evidence-based programs can be costly. There are costs associated with running a tendering process, drafting contracts, and then monitoring the contract. These contracts need to be of sufficient size to merit the contracting costs. Thirdly, the current market is underdeveloped. Evidence-based programs are still relatively new in the UK. Few, if any, providers have an established track record of delivering them. This poses challenges for all three stakeholder groups in this process: delivery organisations, commissioners, and investors. At the same time, there are a number of advantages that come with the commissioning of evidence-based programs. One of the key advantages is increased accountability. Evidence-based programs are clear about expected outcomes. It should therefore be possible to monitor these outcomes within the agreed timeframe so that service providers can be accountable for the outcomes they are achieving. The evaluation of target outcomes allows local authorities to not only identify the achieved results, but also to populate the financial models that are created for, say, payment by results contracts or social impact bonds. Another key advantage of commissioning evidence-based programs is greater specificity. The requirements for evidence-based programs in terms of staffing, training, and delivery can be translated into clear statements for commissioning. This helps to clarify expectations of both commissioners and suppliers and increase transparency in terms of breaking down and pricing the risks of commissioning. Yet another advantage of commissioning evidence-based programs is that they are clear about expected outcomes and therefore amenable to payment by results. The fact that there is an established association between the program and the outcome means that it's less risky for a provider to include a performance-related component in their contract. These are only a few of the challenges and advantages to commissioning evidence-based programs, and we'd be interested to hear more from you in the discussion, which we will now move into. I know that Trin's been collating some questions for us to answer, so we'll take one of the first few questions, and by all means, if you have others, please keep sending them through.
Yeah, and the first question that has come in relates to payment by results contracts, namely, what are the main risks to delivery organization in payment by results contracts? And it's a really good question because in practice, underestimating the risks associated with traditional service contracts, let alone payment by results contracts, is very easy to do. And they often turn into a box-ticking exercise if they happen at all. So a few top risks to watch out for relate to, for example, one of them relates to referrals. So if you don't control the user numbers signing up to your program, you should have contingency plans for a wide range of referral numbers. Another risk relates to performance uncertainty. So you have to question how sensitive is your intervention or delivery plan to variations in effectiveness of your intervention in generating outcomes. So what if outcomes take longer to come through? That will certainly affect the risk levels of the contract. Then there are also contract details. Often the terms in the transfer undertakings that are included in the contract are overlooked, and it is essential for service providers to make sure that they know what responsibilities they're taking on beyond generating the outcomes. And then there are also macroeconomic factors. Something you have to bear in mind is that how is your program affected by either a tanking economy or increased inflation? So these are just to name but a few, but they're definitely dependent on the nature of the contract and the nature of your intervention. Right, we have another question. That one's for Nick. What sort of things would help to sell evidence-based programs when developing the local market?
Okay, this is it's a good question. Well, I think it depends on who you're talking about, but if we take, for example, managers of services, and that could be head teachers, or it could be social service managers, or obviously people working in the youth justice sector, we think that such people are more likely to want to use a program that could be delivered by existing staff. Perhaps they need a bit of retraining or some extra training, but that would seem to make sense. Also, of course, if the program will fill a slot in the timetable that's currently occupied by something else, or maybe something less promising. I guess as well, a manager will be more interested in a program where it's clear how that program contributes to targets or performance indicators that they get assessed against. So those things need to be taken into account when marketing a program, even to some extent, of course, when designing a program. Then, of course, there are people who might have to refer young people or families to programs. The research and experience suggests that then people like that are more likely to refer clients if they are really clear about the target group criteria. That is, they know or have a good sense that the person they're referring is going to be suitable for the program. They also want to know what happens to the client they refer. They want to know whether they get into the program or not, and if they don't, why not? And if they do, then how does the client do? Do they benefit from the program? So making those things clear up front, I guess, is important. And then as well, we need practitioners to buy into programs. Ideally, you don't want to be pushing these things onto reluctant practitioners, whether they're youth justice workers or teachers or social workers. You want those people to want to do the program. So of course, thinking about things that will make the program more attractive is important, and that might have to do with stressing the creative opportunities within the program, stressing the opportunity to gain or practice new skills, to develop one's career, and so on. So those are just a few thoughts about how to sell an evidence-based program when you're developing the local market. Okay, so another question for Trin. Could you comment on the challenges in designing payment by results contracts?
Yes, I certainly can. I think we could have a whole separate webinar on payment by results contracts only. There could be quite a lot of challenges when designing a contract. And if we take the Ministry of Justice contracts that are designed to reduce reoffending and that are scheduled to start in 2015, then the Ministry of Justice, for example, faces quite a few challenges in this process. So, for example, one of the things that they need to consider is the length of contracts. The contracts must be long enough to encourage a wide range of providers to bid while still providing break clauses for those that underperform. And obviously, another thing to consider is the proportion of the contract paid on a successful outcome on a payment by results basis. So on the one hand, it must be big enough to drive innovation and improve performance, but on the other hand, it must be small enough to be a realistic financial model that medium and smaller providers can actually bid for. Then another challenge is that most providers won't actually have a track record in reducing reoffending. So while it is quite reasonable for the price to be part of the awarding criteria of any public contract, it will be actually hard to assess the quality of the services that are likely to be provided. So it's a bit of a gamble. And then there is a question of designing an outcome metric. It has to include, in this example, it has to include both binary and frequency measures of reoffending. So how do you measure all this, and how do you make sure it captures both aspects of offending behavior? And there's also the question of the size of contracts. So on the one hand, the contracts must be large enough to have substantial cohorts so the outcome metrics can actually be valid, but at the same time, they have to be flexible enough to reflect the local needs and existing partnerships. So this is just one example and one type of contract targeted at a specific outcome like reoffending reduction, but the challenges will vary depending on the nature of the interventions and the outcomes we're looking at. There's a question, I think, Nick, I hope you can take that. Are there any tools that you would recommend to help with an outcome-driven commissioning process?
Yes, there are. There are a few off-the-shelf tools that can be used. You might have heard of some of them. Probably the best known one is Communities That Care, which originated in America but has been used here in the UK. Others that you might have heard of, results-based accountability, sometimes referred to as turning the curve. Others that you're perhaps less familiar with, getting to outcomes is one. Common language is another, that's our own method, and then one called evidence to success. I'll say a bit about these. I think the thing to say about them is that they do have several elements in common. So typically they all start off by looking at evidence of need and then thinking how do we want to improve outcomes. Then they think about the type of intervention that's going to be put in place to achieve those outcomes. In other words, the type of services or type of evidence-based programs. And then they require thinking about the investments in those interventions. In other words, what's required to deliver those activities. And then lastly, they normally all have a monitoring process built in as well to see how things go, to see whether things get implemented as intended, and to see how young people and families on the end of those interventions have to see how they do. I think it's important to say they also have differences. So some take a much more scientific approach to measuring need than others. Some might rely exclusively on secondary information, in other words, data that has been collected by someone else, and just assemble that, or they might just seek expert opinion. Others take a more epidemiological approach, like I described earlier in this webinar. Another difference is that they have different standards for determining what the intervention is, or what types of intervention should be delivered. So some rely primarily on evidence-based programs and would set quite a high bar for what those programs should be in terms of their evidence of impact. Others are more interested in innovations, I guess, and they wouldn't require such high levels of evidence. And then, of course, they have different monitoring processes as well. But I think they're all worth looking at. They all come with materials, manuals, and the process tends to be clearly outlined. So yeah, I definitely would recommend some of those. Okay, I think we have time for one more question. I'm going to give this one to Trin. What do you think of the idea that payment by results is actually quite dangerous and creates a situation where those most in need get a much poorer service just because the suppliers want to show improvement in outcomes?
That's a great question. I know we made payment by results sound quite simple in theory, but in practice it's quite a complex thing to implement successfully. And what you just described in a question, the supplier wanting to show improvement in outcomes, and that being the Achilles heel of these contracts, can be true. A good example of that would be the work program contract implemented by the coalition government, which does reward providers with much larger payments when they place people such as recovering drug users who've been on sickness benefits for many years into jobs. However, despite this clear incentive, the overall design of the contract has meant that most providers have concentrated on getting the easiest to place job seekers into work, as this ensures them a continuous cash flow. So the balance of the contract is not entirely right here, and as a result, there's increasing evidence that providers are kind of creaming the easiest cases while providing a minimal service to those in greater need. So it is crucial to be clear on the details relating to outcomes, as well as the monitoring of outcomes, to ensure that the ones most in need get the services they require. So it can happen, but hopefully with a well-designed contract that takes into account the risk that we just earlier described and the challenges we touched upon, should be able to avoid that, or at least minimize it. We have reached now the end of our webinar. Thank you everyone for joining us today, for your attention and for all the questions you sent through. As you probably know, each webinar complements and extends the previous one, so we are certainly hoping that you are going to join us at our next webinar on how to implement evidence-based programs, which will take place on Wednesday, the 15th of May. So we hope to meet you again in 2 weeks' time. Thank you.